You're listening to Medscape's In Discussion series on chronic obstructive pulmonary disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Leah Witt. Dr. Witt is a geriatrician and pulmonologist at the University of California, San Francisco. At UCSF, she is also the Pulmonary Associate Chief for Ambulatory Affairs, a coach for the Pulmonary and Critical Care Medicine Fellowship, and a passionate advocate for improving the care of older adults with chronic lung disease. Dr. Witt is an associate editor, producer, and sometimes co-host with The Curbsiders, a popular internal medicine podcast where she's covered topics on chronic lung disease, geriatrics, and gender equity. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Leah Witt. Welcome back to Season 1 of the Medscape in Discussion COPD podcast series. Today we're talking pulmonary rehab, the most valuable and underutilized treatment for COPD. So first, let me introduce my amazing expert guest, Chris Garvey. I'm thrilled to welcome Chris to the show. She's a pulmonary nurse practitioner. She currently works as a pulmonary rehab consultant after over 2 decades at the University of California, San Francisco. She's former president of the California Thoracic Society and has co-authored several recent pulmonary rehab scientific statements and guidelines, and has served on numerous national and state committees, including as co-chair of the American Thoracic Society's Pulmonary Rehabilitation Section and chair of the ATS Pulmonary Rehabilitation Reimbursement Working Group. Welcome, Chris, to the Medscape in Discussion podcast.
Thank you very much.
Well, we're thrilled to have you here. I wanted to start with a little get-to-know-you question and ask what's on your mind outside of medicine and healthcare.
Yeah, thanks for asking. I'm spending time studying Italian. My husband and I have a flat in rural central Italy, so it's a good motivator, and it's a good balance for trying to get everything right from a pulmonary rehab standpoint in our country.
Oh, that's beautiful. So how are you learning Italian?
I take classes locally in San Francisco. There's an Italian-American museum at Fort Basin, and then I augment it with Duolingo. So it's a good balance of 2 different methods, and I'm making progress. I'm happy.
Oh, amazing. Oh, that's so cultured. The only recent cultural experiences like that I've been into right now is Anti-Culture, which is a reality TV show called Love is Blind. So I don't think we need to go further into that. We should focus on your much more cultured activity. That's beautiful. Let's start with our case, and we have so much to get to in our short episode today. Our case today is about Mr. Rivera. He's a 78-year-old man with COPD who we've been taking care of all season. We're coming back to him. He has group E COPD. That means he has frequent exacerbations, and his FEV1 to FVC ratio is 0.65. His FEV1% predicted is 60%. I think we should just start with the basic question of what is pulmonary rehab, as we're talking to him in our clinic about suggesting he go to pulmonary rehab.
That's a great question. So pulmonary rehabilitation includes several features. It starts with a comprehensive patient assessment to understand their disease, accurate pulmonary diagnosis and comorbidities, and then assessing many features, typically with a 6-minute walk test to look for desaturation with activity, as well as to understand functional capacity, baseline, and balance. So there's a lot that can be gained from that, as well as establish the basis for an exercise prescription. We talk very carefully with the patient about what their goals are, which is really what matters. What do they want to get out of rehab? How can we be of most help to them? And then work with the medical team, the physician that referred the patient, to make sure that this is all making sense. The cornerstone is exercise. And the exercise is 2 features. One is aerobic training to improve endurance, and the other is strength training, resistance training to improve strength. Both are of great value and translate into significant outcomes. In addition to that, we focus on individualized education, targeting long-term behavior change, and also adapting to the limitations that the patient has, maybe climbing stairs or being more isolated, and working to overcome that. Ideally, rehab should include peer support. It's very powerful for patients to know they're not in this alone. They're not the only person that's ever had lung disease. And to see there's people actually better off and worse off than them. It's a very good experience for patients that we really support. After the assessment, we look at both improving physical and psychological condition for the spectrum of people with chronic breathing problems. The strongest evidence base is in COPD, but we've seen very powerful outcomes in fibrotic lung diseases, interstitial lung diseases, as well as nearly every other pulmonary disease stands to benefit.
And Chris, before we get even more into the benefit, do you have a script that you recommend providers use when they're telling patients about what pulmonary rehab is? I'm going to give you mine. You can tell me if I need to work on it. But I tell people this is lung-specific physical therapy, except you get extra education and coaching. And I always say, insurance pays for it. It's a limited benefit. It's not forever. You'll get maybe 4 to 6 weeks, a couple of times a week.
That's great. Well, I'm really glad you asked. What I'd like to emphasize is the message from the clinician that's referring the patient is very powerful. I think patients need to know what they stand to gain by going to rehab, that they will get stronger, they will breathe better. That's my expectation, and I'm very clear about that. And they'll be able to do more of the things they want to do. And that's one of the reasons we want to look at their goals. Their goal is not the same as our goals. Their goal might be to be able to go to a ball game or play 9 holes or go see their grandchildren. So we want to work towards that goal over time in a safe, supportive environment. So what you said is perfect. And I think it really is a key message that some physicians underestimate the power of what they're telling the patient.
I like that idea of allying with the patient by identifying something they're saying they can't do or want to do. And this is kind of a motivating factor. Like, our goal is to get you to that baseball game. So we started to briefly talk about benefit, but over the last couple of years, I feel like it's just one paper after another showing increasingly powerful benefits of pulmonary rehab. So can you just explain or review some of that?
Absolutely. And you're absolutely right. The magnitude of benefits has really accelerated over the last few years. So where we should see a significant benefit is functional capacity, usually measured by improvement in 6-minute walk distance. So the patients overall should improve at least 30 meters. Not everybody does, but most do. Also, improvement in shortness of breath, dyspnea, both at rest and with activity. So there's a lot of opportunity to teach patients tools to control dyspnea, but also that some level of shortness of breath is normal with exercise, and teaching them what's a safe level and when to dial it back a bit if they're getting too short of breath. Quality of life is the sum of all of the outcomes, and that's an important area for improvement. And then the fourth, and certainly a very important one, is mood. There's clear improvement in depression, in some studies equivalent to medication. So you can imagine if people are able to be independent again and feel more like themselves, it can be very helpful from a mood standpoint. Now, what we've seen over the past 2 or 3 years, the work of Peter Lindenauer and Chris Mosier showed us that, one, if a patient with COPD has been hospitalized and receives timely pulmonary rehabilitation within 90 days of discharge, they have a significant likelihood of improved survival, 37% improved survival, and of a significant cost savings. Now, that may not matter to us or the patient, but it definitely matters to Medicare and insurance. And it's a dramatic improvement, mostly because of reduced risk of rehospitalization and reduction in the risk of a subsequent exacerbation.
And if I remember right from those papers, there was a dose effect. Like, the more pulmonary rehab, the lower risk of mortality, reduced hospitalization.
Even every individual visit, and once a person got to 3 extra visits, there was clear, significant improvement in survival. And this was also demonstrated in fibrotic lung disease by Sabina Guler in thorax. And UCSF participated in that study. It was a multi-center retrospective study looking at the impact of pulmonary rehab on survival in fibrotic lung diseases. And it was dose dependent as well. 3 additional visits translated into further significant improvement in survival.
So this just seems like something that people should be running to start and do, but we know it's underutilized, unfortunately. So what do you think the barriers are, both for patients to start and complete and for physicians and other providers to refer?
Some of the barriers, we don't get paid very much. We actually get paid less than half of what cardiac rehab gets paid, which I've worked in both departments. Pulmonary patients are definitely sicker, more complex, and certainly in need of the service. So the reimbursement is not where it should be. We're working on that. We've made some progress, but it's something that we're going to have to really keep working hard at. I think that hospitals making pulmonary rehab a priority, so there's more programs to go around, would help, because some hospitals have waiting lists, and that's a difficult reality for patients to have to wait. We hate to see that, because once they're motivated, we want them to get started. We're seeing some alternative models like telerehab or virtual pulmonary rehab. That is really a very well-established model in Canada and in Europe and in Australia. However, in the US, it's essentially was unheard of until the pandemic. And then we at UCSF, like a lot of centers, created it very quickly to respond to the lockdown and public health emergency. But we know very little in the US, and our healthcare system is driven by a market economy. So it's a little bit of a different model from socialized medicine. So we just did a national survey looking at virtual or telerehab models. Most of them are, interestingly, out of the VA. The VA made a push for this in the past, and so we were able to get a lot of information from them. The other group that are providing this at this point are what I guess I would call a commercial business model, where it's a company that has investors and it's private, and some of them are perhaps a tiny bit less than transparent about everything that's going on. We found a lot of heterogeneity among the subgroup of commercial providers, and that nearly all of them do not provide an in-person assessment. That's not totally surprising, because some of these patients live in rural settings and should be able to access rehab. We don't want to create barriers to that. However, we do want to be sure we're maintaining the quality and effectiveness and safety of pulmonary rehab. So I'm working with a group at ATS to take this further, so we can be ATS can be of as much help as possible to patients and to these programs to know what is the standard of care. We're probably going to be looking at quality metrics for all pulmonary rehab and talk about or focus on how virtual programs can achieve that. So that's our goal.
One of the biggest barriers I see is just, like, as you said, lack of availability of programs and seeing people who live hours away from a urban center, where even in urban centers, there are not, tons and tons of programs. So telerehab does seem to have a huge benefit there. Can you explain, in Canada, Europe, and Australia, is there an in-person component that's required? Is that how it's different, or how does it compare?
That's a great question. Where we get most of the information on virtual programs is out of the Cochrane Review. A couple of years ago, Narelle Cox was the lead author, and all of the programs they assessed provided an in-person assessment prior to going to rehab, and then in the ones that were in the rehab arm, they had a post-rehab assessment as well, so they could assess outcomes. I think there is some heterogeneity in other countries, but I don't think it's the same magnitude as we're finding, because we only found one program of all the commercial entities that responded to the survey. We only found one program that provided any in-person assessment. What that means in the short term, I think, is that it's going to be the physician's role, or they would order a 6-minute walk test at a pulmonary function lab to try to get that information at least accessible and better understand, degree of hypoxemia, if that's a problem, and also balance, and also to some degree inform the tentative exercise prescription.
I definitely want to talk about cost and insurance coverage. We can maybe focus on Medicare, since many or most of the patients, not all, but most, are on Medicare. And I'm interested in coverage for both in-person pulmonary rehab, like center-based rehab, and telepulmonary rehab. So what do we know about cost and coverage?
So for the center-based programs, which is the model in the US that's most common, and also importantly, it's where all of the strong positive outcomes have been identified. All of the research basically is that model. Medicare covers pulmonary rehab, 36 to 72 units or hours per lifetime. Unfortunately, it's a lifetime benefit that's on our list of things to try to address. So it's for COPD, gold stages 2 through 4. Also, during the public health emergency, Medicare added COVID, either suspected or diagnosed COVID, with at least 4 weeks of respiratory impairment. And so those are the two that are covered under pulmonary rehab in hospital-based outpatient pulmonary rehab. Medicare has another avenue called Medicare Administrative Contractors. So they contract with insurance companies. So in California and many states, Noridian is the insurance carrier. This is how other diagnoses get covered, such as interstitial lung disease, pulmonary fibrosis, etc. So what we're looking at are patients that have a physician-diagnosed lung disease, and they have impairment from symptoms, shortness of breath, decreased functional capacity, and other related issues that are part of their impairment from their lung disease. So that is what's covered. It's not technically called pulmonary rehab. It's called outpatient respiratory services, but it's a very similar benefit. So that's traditional outpatient hospital-based pulmonary rehab. And that's billed under something called outpatient hospital system under Medicare. There's something else called the physician fee schedule. That is the way that virtual or tele-rehab is paid for currently. As you can imagine, these commercial entities have a physician. The services are either billed under his or her code or a physician they've hired, their code. So it's a bit of a new world. We're working to understand it, and that the current model, there's a few other variations we're seeing, but that's the most common one currently. If you want to know how to find a pulmonary rehab program, there's two common registries or directories in the U.S. ATS has one called livebetter.org. There's 1,700 programs in the U.S., so you can find a program there for the patient based on their zip code. Our national clinical organization, American Association for Cardiovascular and Pulmonary Rehab, or AACVPR, on their website under program directory is another directory for pulmonary rehab programs.
Do people need to know about the phases of pulmonary rehab? This is something like that I intermittently talk about. We have one phase 3 program in our area, which is continuing pulmonary rehab. I've never seen a phase 1 inpatient program. Does that matter, or how do you talk to patients about that?
The concept matters. Phase 1 would be inpatient rehab, like stroke rehab, but for people with lung disease. So this would be people that have, been on a vent for quite a while and really are starting at a much more challenging level than an outpatient setting would normally take on, although physical therapy is also an option. So that's phase 1. The term is really not fully utilized. Phase 2 is outpatient hospital, is normally the target. Phase 3 is also called maintenance exercise. From the first day the patient comes to the traditional pulmonary rehab program to feel better, breathe better, get stronger, we tell them this has got to be a lifetime of working at staying at the best level possible. Maintenance exercise can be very helpful and very powerful because everybody's in the same boat, and it's a real nice social setting. Plus, it's clinically supervised, which many patients really like. But there isn't always easy access. So a few other options are really important. If the patient can't access it, finding a big store, a Target or Costco, and going as soon as the store opens in the morning and it's kind of empty, and walking around or walking in a mall with a friend, having a good supply, at least a few options, including one they can use if the weather's not good, an indoor option. Going to a gym is okay for some, but not everybody. Some patients don't really identify with a gym setting. So big stores, some nice distraction. Exercise can be kind of boring sometimes. So building in a social part or a place where there's a lot to look at for distraction can be very favorable.
Well, I wanted to finish the episode by talking about the education piece of pulmonary rehab, which is more of a black box to me. And the first question I had for you was, how do you talk about the benefits of exercise to patients? And I think this is something I struggle with. Hopefully I'm getting better at it. But many of the people we're referring have irreversible lung damage from either smoking or interstitial lung disease. And they'll say, how could you possibly make me less short of breath if my you're also saying my lung disease is not going to change? So I'm going to turn it to you, and then I can share how I've come together with a message that I think makes sense. But what do you tell patients about that?
Pulmonary rehab really is, there's no strong evidence for change in lung function. We do everything we can to fix everything outside the lungs. Patients are often severely deconditioned. It's an ugly downward spiral, often worsened by dyspnea. If they have obstructive lung disease, they probably are experiencing some level of dynamic hyperinflation, meaning that the trapped air in their lungs increases in volume and overwhelms the ability to take a deep breath during exercise. But by slowing down their breathing through pursed-lip breathing, as an example, walking upstairs. In San Francisco, we have lots of multi-story buildings with staircases, and this is uniformly a scary thing for patients. So slow, easy breath in through their nose for a count of 2, and then exhaling through pursed lips like they're blowing out a candle for a count of 4. They would ascend 1 or 2 stairs while they're exhaling, and then start over. Slow inhale through the nose, and then exhale as they ascend 1 or 2 more stairs, instead of trying to run up the stairs and to get it over with and then gasping at the top. That's really what we're targeting. For the exercise part, there's clear evidence that they will breathe better. And it's hard to imagine that for exactly the reason you said. But in a safe, informed setting, it's absolutely an expectation unless there's something terribly wrong. If we're not making progress, we would refer the patient back for reassessment to try to understand that.
Yeah, thank you. This is what I share with patients too. Like, actually, we can change the function and strength of your heart pumping, how efficiently your heart pumps, your muscles get stronger, they pump blood more effectively. So really everything outside of the lungs we're working on. Just like, if we train for a 5K or a 10K, even if you didn't have lung disease, you would get in shape to achieve that. So it can be a hard battle to convince people of that. But once somebody's bought in, I feel like you can make some really amazing strides. So, Chris, we have packed in so much information and key points, really useful pearls in this last 25 minutes. I'm wondering if you have any key points that you want to make sure our listeners leave with and resources they should check out.
Yeah, there's great resources out there for pulmonary fibrosis. The Pulmonary Fibrosis Foundation has some recorded sessions that we put together for patients that can't access a program. So at least they can hear some opportunities. The COPD Foundation has great resources for persons with COPD, and they're doing a lot of important things, including trying to better tease out the quality of virtual programs. I think those are very strong patient-centered organizations that can be quite helpful. I think that, again, the role of the physician and the role of the family to support the patient can be very powerful. So things have gotten quite a bit better. When I started working in pulmonary rehab, I had a feeling that physicians thought it was more like witchcraft. Now it's definitely the standard of care. Most patients, probably every patient I see, tells me, I wish I had done this sooner. I think that's very telling.
Thank you so much, Chris. And thank you for your research and advocacy. This is such an incredibly important resource for patients. So I'll summarize and wrap up a great episode. Today we've talked to Chris Garvey about pulmonary rehab. I learned that the physician and provider role in selling pulmonary rehab and the elements of it and the benefits made is so important. And we know that pulmonary rehab is underused and extraordinarily beneficial. So thank you for tuning in. Take a moment to download the Medscape app to listen and subscribe to this podcast series on COPD. This is Dr. Witt for the Medscape in Discussion COPD podcast.
Thanks for listening to Medscape's In Discussion Chronic Obstructive Pulmonary Disease podcast series with our host, Dr. Leah Witt. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on chronic obstructive pulmonary disease.